session today. Welcome everybody, and I want to welcome our guest speakers from England and from Netherlands, and our chairperson as well. And we're gonna start with Professor Barentsz. Please, Dr. Tarek, can you please introduce Professor Barentsz?
Okay, thank you very much for the kind invitation to give this talk. Emergency button. Okay, good. Yeah. Okay, now you're all awake. So, yes, okay. Try it again. So thank you for this kind invitation to give this talk. This morning I will discuss prostate cancer screening and some quality issues. No disclosures. So, with early detection of prostate cancer with screening, what we like to do is, can we reduce the unnecessary harm of screening while maintaining the same detection rate that has been showed by trials that use PSA and trust-guided biopsies, the ERSPC trial. So there is a clear decline, lower mortality if you do screening, but what we need to do is we need to reduce the unnecessary harm. The trust way in doing screening showed a lot of overdiagnosis, a lot of unnecessary biopsies. Overdiagnosis may lead to overtreatment. Not all the patients with a Gleason 3+3 are going to have active surveillance. There are many patients who prefer to have an unnecessary prostatectomy. And I would like to discuss you also the challenges that need to be addressed. So, what is the clinical existing evidence of the value of local MRI? That means for detecting significant cancer. There are at least 4 level of 1A papers. Clear evidence that changed the EAU and the AUA guidelines. It has been summarized by this nice Cochrane analysis, and it showed that on the average there is at least a 33% of avoiding unnecessary biopsy. The detection rate of clinically significant cancer is high, 96% if you perform it well. Furthermore, there is a major decrease in the detection rate of insignificant cancer. So we are reducing the unnecessary harm. The relative index is 0.64. That means that 40% reduction of overdiagnosis. And you can see that the detection of clinically significant cancer is equal to the non-MRI trust biopsy. Okay, if you have an expert center with expert MRI, the no biopsy, so the avoidance of biopsy, is almost 50%. So the better you are, the more certain you are about a positive and a negative diagnosis, and the more you can avoid biopsy. The sensitivity is high, 97% in detecting clinically significant cancer. Now, can it reduce unnecessary harm? Yes, it can. But, there's a but, all the existing papers were in a biopsy-naive population, so it was not a screening setting. What's the difference? In the biopsy-naive situation, that's the clinical situation, the patient is referring himself to a GP and asks for his PSA. And if it's elevated, he is a patient. Whereas in screening, you are invited to have your PSA tested. And theoretically, there may be a difference in those two populations. So, are the advantages of MRI also present in the screening population? What is the existing evidence there? There are many, many papers that show the reduce of biopsy, what is most important in the various populations. If you go from the right to the left, you can see that the prevalence of cancer is decreasing from 50% to 30% to 90% to 3%. And in the orange bar, that is the MRI strategy, whereas the blue bar is the non-MRI strategy. And what you see is that there is a significant reduction of biopsy, which is only necessary in about 10% of patients in a prevalence of 3%. So that is probably the screening population. The prevalence may be in between 19 and 3%. So that means that we have an enormous reduction of biopsies when we use MRI. Let's zoom in into this important patient. Here it was evaluated what's the value of PSA and thrust biopsy, so the regular old way of screening, versus MRI, where Barentsz 3 and to 5 were considered to be positive, and it was a biparametric MRI with 3 planes T2. If you look at the biopsy procedures, you can see that the index is 0.52. That means that there is an almost 50% reduction of biopsies. That's good. If you look at the detection rate of insignificant cancers, you can see that it's 0.38. That means that 62% of insignificant cancers are less detected. So this is reducing significantly the harm of the old way of screening. If you look at the detection rate of clinically significant cancers, 3+4s or higher, it's 1.22, so 22% more. And if you go to the significant cancers, it's even better. This is another study, and I'm just picking out 2 studies just to illustrate what you have. It's MRI versus ultrasonography and just plain PSA, and then followed by biopsy. So if you look at MRI, oops, if you look at MRI, you can see that an MRI with a PIRA score of 4 to 5 versus PSA is having equal positive test results. However, the detection of significant cancer is 11 instead of 7, so significantly more. And also you can see that there is a slight reduce of insignificant cancer. So also this paper shows the value of MRI in the screening population, which is about equal to the clinical population. Now, what are the challenges? First of all, we need to communicate this, the evidence, with the vendors, with patients, and with national health councils. And fortunately here in Egypt you're ahead of others because you already started with a health-directed screening program or a test screening program. That's very good. Long-term results in screening, we need to have results before we can go to the next step. And do they need to be long-term results? Oops, what's happening here? Go back. Okay. So, in long-term results, what is considered to be in oncology, the ground truth is the holy grail is the randomized clinical trial. Well, if we perform the randomized clinical trial, we need to wait for another 15 years. And at that time, I'm 82 and too old to give courses, and perhaps I have my own prostate cancer, so that takes too long. Now, this is important. Insufficient MRI, not enough MRIs, and MRIs with a non-sufficient quality. And most of my talk will be about this. This is what I hear often from urologists. I've seen Dr. Barentsz, but my radiologist can't do it. Okay. Now, this is nice evidence. Quality matters. This is data from the Precision trial. And you can see Barentsz 1 to 2, and here in the middle, Barentsz 3, Barentsz 4 and 5. And you see 2 lines. One is the gray line, that is the non-expert. And the blue, dark blue line is the central reader, that the expert. And what you see is, oops, what's happening here? Come on, guys. Something wrong with the electricity. Okay. So. So what you see is that you have a reduction by experts of the I do not know. It's 21 versus 6%. And there are more positive cases and less negative cases. So the experts do it better. There are less PIRATs 3 in the transition zone. Quality matters. We need a way in measuring quality. We need training, certification, and accreditation. Training is being provided also in this meeting. At 3:30 I will give a workshop, and there are many other workshops. And locally, countries are working, and in Europe we are also working in certification and accreditation. Very soon we will have an accreditation and certification program in Europe for prostate radiology, which is very good. PyQual version 2, the way in testing the quality, objective measurement. In no report, a radiologist is mentioning the quality of a prostate MRI, unless it's very bad. Now, it is mandatory in Europe to mention the quality of your report. And you can judge the quality by looking at T2, diffusion-weighted imaging, and TCE in an objective manner. And there are 4 points to be gained from T2, 4 of diffusion and 2 of DCE. You need to have at least 3 points of the category T2 and diffusion to have a good MRI exam. And it should be mentioned in your report. This will be soon out. It will be soon published. Now, at the left top, you see good quality. At the right, you see poor SNR. Here also the SNR is poor. And if the technician recognizes it and you repeat the scan, you see a better quality. We are looking at the periprostatic structures, and we are looking at the internal structures of the transition zone and the peripheral zone. Also, we look at artifacts. And we look at the other planes. In diffusion-weighted imaging, we look at the quality of the B1400s. We look at the ADC, we look at artifacts. You can see line artifacts in the middle too. You can see that there's a loss of signal at the dorsal part here at the B1400. These are images which are not sufficient, and that is a good quality image. You can see on the left side, it's in the right side of the prostate, a hyper-intense focal lesion, which is a significant cancer. Here you see the ability to identify anatomical structures on the DCE, which is good on the left side and poor on the right side. This is all quantified as objective as possible, looking just at the quality of the images. Now, this is a good quality image, axial T2, just to give you an example. There's a nice internal structure, there are nice prostatic structures to be seen, and this is for the ADC, the B1400. This is ADC, and here you can see that there is a good delineation of the transition zone and the peripheral zone, which is important. If you cannot separate those two zones, if you cannot separate here the peripheral zone from the transition zone, the quality is not good enough. I think I go to the podium because this thing, I think the battery is almost gone. Okay, so this is PyQual. A good quality image of the B1400. You can see here there is a nice delineation, bright structure, and the rest is grayish. That's good. So this is a good image. Now, another thing is we need too many MRIs. A tsunami of MRIs is approaching if we do screening. So how do we increase the number of MRIs? First of all, we can do a pre-test before MRI that significantly can reduce the number of MRIs that we need to perform. We have the Select MDX, we have the Stockholm 3 test, we have PSA density, And we have all kind of risk calculators like the prostate, the Rotterdam prostate risk calculator. Select MDX. It avoids biopsy in 38%. It detects clinically significant cancer in 28% and insignificant cancer in 15%. If you do only MRI, you can see that it avoids biopsy in 49%. The detection rate of the others is about equal. However, if you do select MDX and then an MRI, it avoids biopsy in 60% in the clinical population, and it detects insignificant cancer in only 10%. So it saves 38% of MRIs. So the use of a pretest is quite good. Stockholm 3, actually similar results. MR-targeted biopsy in men with a Stockholm 3 test, which is positive. The lower line, there is a relative change in the number of biopsy procedures of 0.45. That means a reduction of 55%. There is low-grade cancer reduction of 70%. And there is an equal recognition of significant cancers. With the risk calculator, it is, this is the calculator that is being advised by the EAU. Patients who have an elevated PSA, they go into a scheme with MRI, and actually before you do an MRI you have the risk calculator, and also after the MRI. It can be found at the internet from Popple publication. This is what the EAU is advocating. However, the Rotterdam risk calculator could prevent MRI, yes, in 37%, but it was at the cost of 18% of clinically significant cancers missed. This is a local evaluation in the Netherlands. So it underestimates the risk of clinically significant cancer in a Dutch cohort. And what you need to do with risk calculators is carefully evaluate for what population are they being made. Sometimes you need to calibrate the model for the incidence, so the number of prostate cancers that you have in your population. It needs adjustment, and then they are good. PSA density, very important. In my clinic, I always use it. If the PSA density is above 0.15, I look twice as good. If you look at the negative MRI followed by targeted systematic biopsy, you can see the detection rate at baseline and 13% at 10 years. If you do no biopsy with a low PSA density and a no tumor at the finger and a negative family history, there will be a reduction of 56% in biopsies, and you will detect 21 less insignificant cancers and only just a very small amount of clinically significant cancers. So the message is, if you have a low PSA density, you can consider in not doing a biopsy. This is the determination of the threshold where you can find tumors in PIRADS 3 with the PSA density. If the PSA density is above 0.15, you need to do a biopsy in PIRADS 3, otherwise don't do it. Such case, you can see here the axial T2, you can see in the middle the diffusion, wash out in the top, and you see a coronal T2. And what you see is a PIRADS 2, no lesions. However, the PSA density is 0.53, which is way too high. So in those patients, you do a systematic biopsy, or you can just target the area of the washout, which is very sensitive for cancer. And in this case, there was a Gleason 4+3 detected based on washout. So the message is PIRADS 2 with high PSA density. That's what I call a dirty PIRADS 2, considering doing biopsy. So PSA density plays an enormous role. Also the scenario, if you have a biopsy naive patient or screening, you want to do high specificity reading. You want to detect as many cancers as possible. However, this does not need to go at the cost of a high false positive rate. You do not want to do the population harm. So false positives in screening or biopsy naive is more important than detecting cancers. Whereas in a post-negative trust, high suspicion, You need to do high sensitivity reading. The false negative rate is more important than the false positive rate. You want to find a clinically significant cancer in this positive clinical patient. This is a slide which I got from Anwar Padani. What is the optimal threshold for positive and negative MRI scans for biopsy decision? It's 3 to 5 versus 4 to 5. Well, 3 to 5, so wide, that is a secondary care. You want to be sensitive, less false negatives. Whereas in PIDES 4 to 5, I think you should use that for screening because you want to reduce the harm. You want to have as low patients as possible with a false positive result. Again, too many MRIs. How can we reduce? I will speed up a bit. This is Max Verstappen. Speed up. How can we speed up MRI? One thing is no contrast. Only 2 planes instead of 3 planes. AI for acquisition, AI for interpretation. AI will be discussed a lot by Anwar Padani the next talk. Non-contrast, to DCE or not to DCE? That is the question. Okay, paper of our group shows not 2 MRIs per hour, not 3 MRIs per hour, but 4 MRIs per hour. No sagittal, no coronal, no DCE. Only 1 plane, T2 and diffusion. Good. What did it show? It showed only 1% increase of insignificant cancer, 2% increase of biopsy, but an equal detection rate of clinically significant cancer. So, it's good. Specificity went down a bit, so be careful. So this may be a very good tool for screening. What it actually is, let's start the video. This is a T2 with superimposed of a B1400. And now you see just the manogram. You just look at the images, you go up and down, and there is the tumor. You have the anatomy, you have diffusion. This is all you need. And if you combine this with artificial intelligence, you can do many MRIs, 4 per hour at least. Okay, AI. I will speed up a bit because the next speaker will deal with it. What is important that if you do the acquisition, now it takes 15 minutes. With AI, it takes 8 minutes. Or you can use it to improve quality. Interpretation, important. Now here you see the ROC curve. And the blue curve is MP-MRI artificial intelligence. And you see the various studies. Now, here you see the PROMISE study, and you can see that the sensitivity could be a little bit better. The same with MRI. First, this is the 4M study, the expert-driven study, and you can see that the MP-MRI artificial intelligence is just about that. So you can see that this is very good. MP-MRI, radiologist plus MRI. One case, what's your diagnosis? T2. ADC, well, there's a black hole here and a white area. It enhances and shows extracapsular disease, PIDES 4 or 5. And this is how artificial intelligence is doing it. It's giving a color and it's producing a percentage. It's 92% that this is a significant cancer. I think this is the future. And Dr. Padani and I, we have been discussing whether we are using PIRETs in the future or whether it just will be a percentage of the probability that there is a significant cancer. A few words about cost. Most studies show that MRI, despite the fact that you use an expensive MRI machine, is cost effective compared to non-MRI. If you look at screening, screening is costing a PSA test of 10 euros. The MRI in our country, if you do it biparametric, is going down to about 95 euros. The treatment of an early detected cancer is 5 to 10,000 euro. Now let's see if we do not do screening, what's happening then? You will have an overdiagnosis, sorry, this is, at least you will, if you do the screening, then you can see that there is a reduction of biopsies compared to TRUS. There is a reduction of overdiagnosis. It's a non-costly refractory disease. So if you have a metastatic disease, the cost is not 5 to 10,000, but it's 24,000 a year. Oops. And there are many prostate cancer deaths, more than in when you don't do screening. So that gives also an increased professional lifespan. So these are the advantages on the right for screening, and these are the cost of screening. So this is what it saves, and this is what it costs. So it costs about 7,000 euros, and with that you save many biopsies, overdiagnosis, costly metastatic therapy, and less death. So it's a winner. Conclusions. The benefits of screening. MRI can detect clinically significant cancers that may be missed by PSA, diarrhea, and systematic biopsy. The English studies clearly show that perhaps you shouldn't do PSA testing at all. MRI can reduce the overdiagnosis, avoiding unnecessary biopsies for low-risk cancers. And it can help in improving patient management, accurate diagnosis, and guiding treatment decisions. Limitations is availability of high-quality MRI, and that is crucial. We need to teach, and we need to find a way to get better. The interpretation requires a specialized training. It's not easy, however, there will be AI in the future. And the false positives are important. We want to reduce the harm as much as possible, and we are looking in ways in doing that. With this, I come to the end of my talk, and well, thank you very much for your attention.
Thank you very much, Professor Barentsz. Any questions or comments?
Professor Torre is going to introduce Professor Badani. Thank you, Professor Barentsz. No, with the question at the end, Professor Barentsz. A lot of questions in the end.
So Professor Badani will be introduced by Dr. Ala Mishrif, please.